السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. أعزائي الطلبة, this lecture about neck lumps, congenital neck remnants, thyroglossal cyst. The thyroid gland develops at the base of the tongue and descends through the tissue of the neck to its final position overlying the trachea. It leaves a tract which runs from the foramen cecum of the tongue to the thyroid gland. This tract curves around the body of hyoid bone. Thyroglossal cysts and fistulae arise from congenital abnormalities of this process. This picture shows the process of mechanism of descending of thyroid gland from the base of the tongue to its final position in front of the second and third tracheal rings. Failure of this mechanism of descending of thyroid gland at the base of the tongue is the cause of lingual thyroid. So this is a lingual thyroid. Signs and symptoms. These may present as a midline, apparent median swelling, or a discharging sinus. The cyst will rise on tongue protrusion due to their attachment to the tongue base and the hyoid bone. They are common in children, teenagers, and young adults. Treatment by surgical excision. The operation is called cyst strength operation. Before surgical excision of the lesion, ensure that there is a normal functioning thyroid gland in its usual position in the neck by doing thyroid scan. This child presents with a midline cystic swelling, which is a thyroglossal cyst, and this is a thyroglossal fistula. Usually we do ultrasound of the neck. This is an axial CT scan of the neck showing a soft tissue mass at the level of the hyoid bone. This is a cyst strength operation. It involves removing of the lesion plus the tissue block between the lesion and the hyoid, plus the mid portion of the hyoid bone, and any associated tract passing to the foramen cecum of the tongue. Branchial cyst. A branchial cyst thought to develop from vestigial remnants of the second branchial cleft. This is the first theory. It is usually lined by a squamous epithelium and contain thick turbid fluid full of cholesterol crystals, and this is important in diagnosis of branchial cyst. We send fine needle aspiration for presence of cholesterol crystals, which is a diagnostic for the branchial cyst. Other theories regarding the formation of branchial cyst, they considered branchial cyst as a cystic transformation of cervical lymph nodes. These common benign neck cysts usually appears before the age of 30. They occur at the junction of the upper third and lower 2/3 of the sternomastoid muscle. They are often arise following an upper respiratory tract infection. Branchial cysts are usually asymptomatic, but they may become painful due to secondary infection because of the presence of a lymph tissue in the wall of the branchial cyst. A fine needle aspiration cytology test yields a pulse-like aspirate that is rich in cholesterol crystals. This is the typical appearance of a branchial cyst, lateral cystic mass present at the junction of the upper 1/3 and the middle third of the sternomastoid. And this is another picture of a branchial cyst. Usually we do ultrasound of the neck, and this is an axial CT scan of the neck showing a well demarcated, low attenuated cystic swelling between the sternomastoid and the thyroid cartilage. Usually we do surgical excision of the branchial cyst with the associated tract which passing between the branch of the common carotid artery, between the external and internal carotid arteries. Dermoid cyst. These cysts lie anywhere between the chin and suprasternal notch. They arise from defect in the fusion of the midline and are an example of an inclusion cyst. They present as a painless midline swelling above the hyoid bone. This is the most common site of the dermoid cyst, and do not move on swallowing or tongue protrusion. Treatment by surgical excision of the cyst. Dermoid cyst can occur anywhere in the midline between the chin and the suprasternum. This is the appearance of dermoid cyst, and this is another picture of a dermoid cyst. Cystic hygroma. These are a rare benign lymphangioma found in neonates and infants. They insinuate and penetrate between the tissue of the neck and may reach massive size. They may cause compromised airway symptom. Treatment involves securing the airway where necessary, and surgical excision can be staged, and avoid using a sclerosing agent. This is the typical appearance of a cystic hygroma, which is present in the posterior triangle in the neonates, and the positive sign of cystic hygroma is positive transillumination. This is a massive cystic hygroma which can cause an airway obstruction. Ludwig's angina. It's named after a German physician, Wilhelm Friedrich von Ludwig, in 1836. This is a rare infection of submandibular space. It is usually occurs as a result of dental infection. It is more common in adults. So Ludwig's angina is infection of the submandibular space, which is a potential space found below the tongue. The submandibular space divided into two spaces: the sublingual space, which lies above the mylohyoid muscle, and the submaxillary space, which lies below the mylohyoid muscle. Infection in the submandibular space can cause displacement of the tongue backward and cause obstruction of the oropharyngeal airway. This is the appearance of Ludwig's angina, cellulitis of the floor of the mouth and the submental space. Signs and symptoms. These include pyrexia, drooling, teresmus because of the irritation of the pterygoid muscles, airway compromise due to backward displacement of the tongue. There may be a firm thickening of the tissue of the floor of the mouth, and paste appreciated on bimanual palpation, by palpation of the floor of the mouth and the submental region. Lateral X-ray shows a gas-forming infection in the submandibular space, and this is a gas-forming infection in the floor of the mouth. Treatment by securing the airway, either by nasopharyngeal airway or tracheostomy, heavy dose of antibiotic using augmentin, and multiple submental incisions. So treatment by high dose of intravenous broad-spectrum antibiotics, augmentin, secure the airway, try nasopharyngeal airway first, since this often will suffice, but when necessary consider tracheostomy. Surgical incision is often unsatisfying since little pus may drain away. The most important features regarding the evaluation of a neck mass are the age of the patient and the location of the mass in the neck. Under the age of 15 years, we consider the mass is inflammatory, then congenital, and lastly neoplastic. Between the 15 years up to 40 years, the same diagnosis: inflammatory, congenital, and then neoplastic. But above the age of 40 years, we should consider a neoplastic, and to prove otherwise, then inflammatory and congenital. In diagnosis of a lump in the neck, we should consider the following signs: the size, site, shape, surface, consistency, fixation to the deep and superficial structures, pulsation, compression, transformation, and bruit. So the differential diagnosis of a neck mass, they are divided into whatever the mass is, a midline or lateral neck mass. If the mass a midline, we should consider number 1, thyroid isthmus swelling, which is the most common in adult. Then thyroglossal cyst, lump moving when patient stick out the tongue, laryngeal swelling, segmental lymph nodes, and then dermoid cyst. If the mass is a lateral neck mass, then is the mass in the anterior triangle or in the posterior triangle? If the mass in the anterior triangle, then the differential diagnoses are thyroid lobe swelling, pharyngeal pouch, submandibular gland swelling, branchial cyst, or lymph nodes, or parotid gland swelling. If the mass in the posterior triangle, so the differential diagnosis, number 1, lymph nodes, then carotid artery aneurysm, carotid body tumor, cystic hygroma, and cervical rib. Thank you very much.